Greetings, welcome to session 5 of the Lurie Children's Pediatric Virtual Roundtable Series with the Potocsnak Family Division of Adolescent and Young Adult Medicine. My name is Chad Worley, and I am the Lurie Children's Physician Liaison for the north side of the city and north and northwest suburbs. I'm joined by my liaison colleagues, Paula Nowak and Julie Kalkbrenner. And in this session this morning, we will introduce you to Dr. Rahmandar and Lindsay Eilers, and they will discuss effective screening for substance use in a busy practice. The Lurie Children's Potocsnak Family Division of Adolescent and Young Medicine provides comprehensive services to adolescents and young adults. We accept new patients between the ages of 12 and 22 years of age. All patients are followed until their 25th birthday. Now, before I turn it over to our presenters, I'd like to remind you that we are recording these sessions. We encourage engagement. Last 4 sessions, we've had lots of questions and a lot of great engagement between the community providers and our presenters. So we encourage you to keep doing that. However, due to the large audiences we've been having, we cannot go live and answer your raised hand. So please type your questions into the Q&A section, and we will be sure to ask those questions to the presenters after their session. And if you have continued dialogue, keep chatting away and we'll answer those too. Now that we got all that out of the way, I'm going to ask Dr. Rahmandar and Lindsay to take over the screen and start their presentation. And thank you again.
All right. Good morning, everybody. Give me a minute.
All right. We could see your screen and it looks great. Thank you.
Great. Thanks for having us and everybody who's here for waking up early, and for those watching, or the recorded session. Hello, I'm Rahmandar, the medical director of our substance use and prevention program and adolescent medicine pediatrician. And Lindsay Eilers is here, our wonderful licensed clinical social worker, CADC, and she will be here to answer questions and be my backup as we go through this. So great. So by the end of the session, we hope that you'll be able to use appropriate methods to screen adolescents for substance use, articulate the value and limitation of urine drug screens in the clinical practice, and provide effective brief interventions to teens using substances. Just some background, which you guys probably have an overall sense of. These are a graph of the substances that have been tried by Illinois high schoolers. The dark blue line is the percent of high school students in our state who reported ever trying the substance. And then the lighter blue are the percentage of students who report current use, so past 30-day use. And you can see that the top substances reported at the bottom are alcohol, e-cigarettes, marijuana or cannabis, and then cigarettes. And really, you've known about the e-cigarette epidemic that has hit our country. And really, after decades of decreased cigarette use, from peaking in the 90s among teenagers, we had all-time lows until e-cigarettes came out and are really what are driving tobacco use among teens. So let's start with a case that will kind of be what guides us through this session. And we have Lacey, who's a 15-year-old female who comes in for her annual physical. While her mother is parking the car because they were running late, you start the visit with Lacey. And she asks, as you guys are talking, are you going to tell my parents? And so, other sessions may have gotten into this, but this is important for everything we do in adolescent medicine, honestly. But, for substance use in particular, confidential care is important because, teens are more likely to access care, answer honestly, and come back and see you. It's recommended by major medical associations, and in Illinois, minors can consent to substance use treatment, though of course, family involvement is beneficial as allowed, and other supportive adults can be great when teens consent. But of course, there are limits to confidentiality, and, just wanted to kind of bring up, things that may come up related to substance use and what, can maybe drive some fears around addressing these issues in a clinical setting. So, of course, breaking confidentiality is never, rarely black and white. It's really up to your clinical judgment. The goals would be to prevent imminent harm to the patient or others, protect the patient's health and safety. And the more recent the activity, the more immediate the need to address this with a trusted adult. And if you feel that there's something that would be important to talk with the parents about, it's helpful, while you're still having time with the patient, to discuss why it's necessary, what details you're going to share, because sometimes the thing that the patient might be most afraid of is you disclosing who they were using with, not that they used. And so that sometimes can kind of smooth over if there's, areas that are appropriate for negotiation, allowing the patient to make reasonable choices in what's shared, and how it's told. And so who will disclose? So it's important that you know that it was disclosed, but does the patient want to tell on their own? And then you follow up with them after they have some private time with their parent. Do they want you to tell the parent without them in the room? Figuring that out. Talking about how disclosure will help, and emphasizing the patient's positive attributes with the patient themselves and also with their parent. So praising their honesty, any change that they've already made, really highlighting that and the healthy changes that they've done already, and then, their willingness to make further changes in the future. And then, if they've accepted other evaluation or treatment. And so some example behaviors that may be more clear, but still, I think that there's some gray area here because if there's somebody who's accepting treatment and doesn't want family involved, and that's how they're going to engage, and you're going to check in and make sure that they are engaging, it's still in certain circumstances might be appropriate to maintain that confidentiality so they can get consent to confidential substance use treatment. So, you're always making clinical decisions. So, injection drug use, withdrawal symptom, especially deadly withdrawal symptoms from alcohol or benzodiazepines, continued use with a history of emergency room visits or inpatient admissions, mixing sedatives or, mixing pills or powders, frequent or excessive binge drinking or driving while intoxicated. Okay. And then when the patient's mom comes in, she grabs you in the hall and says, "Can you do a secret drug test?" So when to drug test, this, certainly has a place in emergencies when somebody comes to the, is obtunded or have altered mental status, in a substance use treatment program, in probation system, drug courts, that's done. And then, potentially has a place when somebody comes in with behavioral and mental health concerns. This could help with an honest conversation, but really in all settings, would recommend the AP would recommend getting adolescent consent, except in emergencies, consent to do the drug screen and consent to release the results. So, yeah, I would not recommend secret drug screens. And urine drug testing, really, the pros can be that it's, a point of care drug test can be fairly inexpensive. You can get instant results that you can address in the moment. And there's many panel options, so you can pick one and tailor it to the substances that are, being used in your community. Cons, it's invasive, especially if you're using direct observation for getting urine. Urine testing is definitely susceptible to tampering, especially if you're not using, strict protocols with direct observation, which most pediatricians are not doing, because those are tricky. And so tampering by, many means, by giving somebody else's urine, by putting, diluting with water, by putting other substances in. False positives can happen with cross reactions, or, medications that somebody's actually taking, coming up as positive for an illicit substance. False negatives. And, this certainly can happen anytime somebody's using something that's not on the panel, when somebody's using outside of the window of detection for a substance, and or that the samples too dilute to pick things up, and it can't tell the difference between appropriate use or misuse of a prescribed substance. So, they're not the end all and be all, and they can be tricky. And I think, when a parent asks for a secret drug test, understanding um, understanding what their concerns are, and kind of assessing would a urine drug test be helpful in this setting, discussing with the patient, and then also saying, even if the patient declines a urine drug test, that doesn't mean we ignore your concerns. I think we can, figuring out how to really address them, even if you don't get that test. Okay. And so see that somebody was asking to clarify what age are you referring to when stating adolescent. So in our state, 12 and above can access substance use treatment if you're asking for what the law is stating. And please clarify if that was referring to another statement when we're referring to adolescent. And then we can I think we'll get to the CRAFT screening question. We will actually talk deeply about that and have more discussion around that. So we'll definitely get to that, Natasha. Thank you. Okay, so drug testing bottom line, this is part of a comprehensive evaluation, not a standalone measure. It has its limitations, risk for misinterpretation. So this is hard for doctors to do. So what can we do? And the recommendations from the AAP would be, and SAMHSA would be SBIRT. And so SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. So screening using validated screening tools or asking about substance use, fortunately, does not increase substance use, just like suicidality screening. It doesn't put the idea in teens' head. And in their head to use. So it can catch what clinical impression alone might miss, and especially using validated tools as opposed to asking questions that we just have in our head, or using the head screener shades. And you can bill for it. And so I typically use the 96127. But depending on the payer, your billing team might recommend to use the 96160. So talking to your team might be the most helpful in clarifying that. Here are a list of freely available validated tools in adolescents, and we'll focus on the CRAFT and the newest CRAFT that's out there, the CRAFT 2.1 plus N. But there's other options certainly available. The S2BI, or Screening to Brief Intervention, and BSTAD, Brief Screener for Tobacco, Alcohol, and Other Drugs, have electronic versions on the NIDA website right there, where you can just have them pull it up on their phone, or if you have a tablet or computer in the room for somebody in the patient, you can go through it with them. But of course you're busy, so why not just let them fill it out on their own? They can do it and then just show you the results. And so that can be great. And hopefully the S2BI, they're validating an e-cigarette question. So hopefully that will get added once that's completed. And then we won't really go into the NIAAA youth alcohol screen because it's really just asked about alcohol. But we'll dive into the CRAFT now. And so got another patient who's coming in with dysuria and abdominal pain. Her urine dip had a really low spec grav, and the medical assistant noted that the sample was almost clear and really cold. And so the patient was caught vaping this weekend and was worried about that you were actually getting her urine for a drug test and not a pregnancy test, or to check it for infection. And so she put water in it. And so while she's getting changed into the gown, you give her the CRAFT 2.1N, and this can be done on paper and can be built into your EHR as well, and may already have been. So just close the Q&A for a minute. So this is what the newest CRAFT looks like, and they are constantly updating it with newer languages that they have it available in, and testing questions. And so, but this one's been out for a couple of years, and I find it particularly useful because it asks about substances, that we care about and can address. So, in the past 12 months, how many days did you drink, alcohol, use any cannabis products or synthetic cannabis, use anything else to get high, use any tobacco or nicotine products? And then everybody should be answering the CAR question. And so even if they reported no use, they want to know if they've ever ridden in a car driven by somebody, including themselves, who have been intoxicated. And then if they had answered any past year use for alcohol, cannabis, or other substances to get high, they should answer the rest of the craft questions about using to relax, using while alone, ever forgetting while using, have family or friends ever told them they should cut back, and have they ever gotten into trouble? And anybody who's reported past year nicotine or tobacco use should answer these questions, which are the Hooked on Nicotine checklist, or HONK, and really just ask questions around difficulty quitting, or signs of addiction. And there's no cutoffs here. It's just the more positive, the more likely they are to have be headed towards addiction and have trouble with controlling their nicotine use. And so the cutoffs for the craft manual gives you these, but low risk would be no past year use and a craft score of 0. And they recommend offering praise and encouragement, and also, really talking about the risks and encouraging them to continue making healthy choices around how they get home and get around. No past year use, and a yes to the CAR question, or past year use and just a 0 or 1 on the craft questions. And so that would be medium risk, and really recommend brief advice, since this is just, not concerning for not showing signs of a substance use disorder. So maybe some advice might be helpful and can make people make healthier changes in the future. And then, following up in the future. And then high risk would be anybody who's had past 12-month use on the craft, plus a craft score of 2 or higher. And this would be where you kind of want to do brief advice, but also maybe this would be a place for more intensive motivational interviewing and follow-up, and then potentially referring to treatment for those who you're particularly concerned about, or those who are interested in treatment. And then here are, and I think we already went over this. So I wanted to just go into I know somebody had a question on the craft about they had a patient who divulged that they had been in the car with mom and dad while they were drinking, and didn't know if it was a couple drinks or how incapacitated they really were. And he didn't know any advice on this situation. And I know that's really hard. But, I think that's where, I think you can, when you have concerns about what adults are doing around their youth, I mean, that is certainly a risk, and that can be a place where getting some more information from the family, providing advice, talking to the teen privately about ways that they can, get home safely, and, not getting in the car with someone when they're concerned about an adult, and then, providing counseling to the family. And then, that as a mandated reporter, that what is it that, what is it that makes you need to call DCFS? And I think that it's really situation dependent on how concerned, what information you have there, and how concerned, and of course, if anybody else, we can certainly talk more about this at the end, for folks and how they've managed this before. But I know it's tricky, especially when the teen's like, I have no idea that they had beer. I don't know. And you're like, what? It's hard always to know what to do about it. It is. Sorry, I don't always have clear answers, but okay. All right. Okay. So, all right, so the patient lets you know that they started vaping because they liked flavors and only drink at parties. And so just going to leave these, and you'll have, these slides to go over, because I know we're running out of time. I want to have some time for more discussion and Q&A, but doing brief intervention, it makes it, more salient for the teen if you make it relevant to them. So, these may be patients you've seen, their whole life. So you have done a social history on them. So you understand what they're into, and, that their tobacco use or whatever could affect their appearance, their breath, their sports performance, if they're putting things into their lungs, or, they're smoking cannabis and they have low motivation, that nicotine or tobacco will not help with weight loss. All of the substance use can be expensive, and that particularly the tobacco industry has tried to target youth and has deceived them, and youth don't like that. So here's an example of what you could say to a youth who's just started, vaped a couple times, and this could be effective in, identifying some areas that might motivate them to stay away from it in the future. And then, motivational interviewing for youth who've had more use. And the general principles of this are expressing empathy through reflective listening, developing discrepancies between the patient's goals or values and their current behavior, and helping those kind of line up in the future. And really, by helping them, it's helping the teen identify ways that those can line up in the future, avoiding argument and direct confrontation, which, certainly can be hard when you're like, oh, just do this, but that doesn't work. You want the teen to really identify that, and then they're more likely to actually do it than an adult just telling them, just say no. Adjust to the patient's resistance rather than opposing it directly, and supporting their self-advocacy and optimism. So using open-ended questions, letting them tell you what's been going on around their substance use, using summarizing statements and just kind of summarizing your understanding lets them clarify, but also can let them hear what they're telling you back at them, and how they can say, maybe that doesn't make sense. Affirming them, as they're talking about their substance use, and, oh, that must have been hard, or I can see that it's been hard for you to stop. Eliciting self-motivational statements, because that's where the money is here, and using reflective listening and reflecting back what you're hearing. And so here's an example of what that would be. And I think these can be helpful when, simple reflection, repeating with a patient statement in a neutral way. So I don't plan to quit vaping anytime soon. So you don't think abstinence would work for you right now, or double-sided reflection, acknowledging what the patient said, but also acknowledging that they said the contrary in the past. So I know you want me to give up smoking weed completely, but I'm not going to do that. You can see that there are some real problems here, but you're not willing to think about quitting altogether, and, letting the patient respond to that, and shifting focus. So I can't stop drinking when all my friends are. Whoa, you're way ahead of me. We're still exploring your concerns about whether you can get into college. We're not ready to decide how, drinking, sorry, and this fits into your goals. So, and I'm not going to, we've got a couple more, and let's get some time for, so some medications can be helpful, which of course, happy to talk through that, see patients for that. But I don't want to get into that in this short talk, but, happy to take referrals or questions about patients, and, refer them the same way you refer anybody to adolescent medicine. And we're an outpatient program. We do individual treatment at this point. We're continuing to grow over time, and we take any insurance. So, and then for other people who may not be near us, or, may have family members who could use help, here's the Illinois helpline for opioids and other substances. And they can use the website, call, or text even. Okay.
That was great. Can you do me a favor, since you have your screen up?
Yeah.
Can you go back to your referral page?
Mm-hmm.
Let's keep that up for people to stare at while we're talking.
Yeah.
Because that answers a lot of our questions that we're going to go to right now. Before I get to Julie, if she's going to ask some questions, I kind of want to get back to that, the craft screening question that was up there. Just one comment that I'd like to make was, I think it's pretty neat that they have a patient that's so aware and confident and they have such a great relationship with their pediatrician to actually ask that question. So I thought that's encouraging from my end to hear stuff like that. So I thought that was pretty neat. All right, Julie, you want to go ahead and take it away?
So we did have another question just come in. What do you do when patients say, I will take care of myself, I don't need any therapy or your support?
Mm-hmm. Yeah. Hey, Lindsay, you want to take that?
Yeah, that's a tough one. And then typically if that's the case, I really work with them on, okay, well, what kind of brought you in today? If you think everything is good, I kind of go through like their functioning, like how's school going, how are friendships, how are relationships at home? Are your parents okay with this? And if this is creating conflict at home. So I really kind of go through like a slew of like areas of functioning and where it could be maybe not as amazing as they think it might be. And then sometimes if they are in to say, see me, and their parents have them there, I work with them on, okay, if like you don't really want to work on stopping your use, what can we do to kind of reduce your use? So what can we work on to kind of make some safer choices? So a lot of times kids will come in and identify like their parents will identify like weed, for example. And that's their biggest concern when lo and behold, we find out there's actually quite a bit of nicotine going on. So usually I take that opportunity to kind of do a lot of psychoeducation. And all along, I'm not saying, I'm saying you need to stop or this is a problem, but this is some things I want you to consider. These are some things I want you to be aware of. And so it really helps them kind of get to a point of where maybe they can think of like that aha moment of like, oh, okay, I could kind of see where maybe I shouldn't be doing this or I shouldn't be doing that, or I could adjust it in this area. So you really want to kind of work on building that agency in their mind of like, I want to make this change. I want to do something different. But it is really tough. So usually I just kind of sit with them and work with them and figure out what are some areas of their life that maybe there might be some challenges or struggles.
Okay, so you guys really work as a team with social work and Dr. Rahmandar. Can you talk a little bit about when social work steps in with the practice?
Well, patients who are referred directly to our substance use program will talk with our medical social worker initially on the phone to get some more information, to answer questions about the program, and then set up a time for an in-person intake that would be with the medical social worker and our therapist. And then, when somebody identifies substance use that could be helped by medication, or they're interested in considering medication for like co-occurring mental health conditions, or they have some other reproductive health care need or something like that, then I'll see them. Certainly if we have anybody referred to us with opioid use, I'll try to get them in to see me as soon as possible so that we can talk about medications and make sure they have naloxone overdose reversal medication and things like that on hand. So, but most people go through therapy and then are linked to the medical services as interested or appropriate.
Okay. All right. We have another question. This doctor writes in, I have a hard time getting kids to buy in if I encourage abstinence from using. Don't know if this is the right thing, but I now focus more on safe use, trying to limit use, not using alone, the reasons they use, etc. What are your thoughts on that?
Yeah, I'm right. I think for somebody, it depends on like how often they've used, how much they've used. For somebody who hasn't used, for somebody who's just started, using or tried a couple of times, telling people not to use can be effective. But for people that have had regular use, that's not effective. So figuring out, what their goals are, and yes, making things safer so they don't die from it, and then linking it with their goals and how their use kind of is impacting their goals. And I just wanted to highlight, I think this really cool free motivational interviewing that's engaging adolescent patients around marijuana use. And it's this interactive, you can get C's. And I think that's helpful in kind of, I think people understandably feel powerless sometimes when you're like, what can I do as this lame pediatrician? And I'm talking to this teen who do they care what I have to say? And, they can. And, if you make it, you care about what they want to do, they might come back to see you, and you don't have to solve everything in one visit. As this is something you can chip away at over time.
Okay, hopefully that helps. And then we have another question. Can an adolescent be forced to treatment against their will? I'm having a challenging time understanding steps to this in a situation where a teen is resisting to treatment and denying any substance use, but is showing extreme signs of addiction. Is it a good time to refer possibly to you, or how would you handle a situation like that?
Yeah, I mean, it is hard to force anybody into treatment that's not in a legal system. And, there's kind of conflicting evidence if that's really helpful. But I think parents have power in ways they don't know. And so sometimes, a teen in your office might be like, I'm not going to do it. But, a parent can make appointments. We have a lot of teens don't want to come see us, and their parents make their appointment. They show up and then they're like, oh, Lindsay is not so scary. And then, and she cares about what I say, not just what my parents tell her to do. And they might keep showing back up. So, giving parents that, the information about where to go and options, and that it's certainly we know we're not it for everybody, and there's different levels of care that people may need at different times. And so just trying to sometimes getting the foot in the door and saying, can you give this a try for a couple visits, especially if you're really concerned about their health and safety.
All right, thank you. And then I just have one last question. Kids Doc is the best way to call for an appointment, and how quickly are you able to start with the intake screening?
Yeah, we get linked to social work right away. And that's kind of helpful in us triaging too. Right now, Lindsay's availability after school hours is tough. There's a wait list for that. We're hoping have an open position for another therapist too. And so, we hope that availability won't be terrible in the future, but right now, wait list for after school, but for, people who are working or in college that, and have daytime availability, that's still an option. And, we're hoping to have mutual aid support groups like Smart Recovery, which is, people might, of course, probably know about AANA, but this is kind of a youth focused one. And so other engagement opportunities and recovery opportunities for youth if, coming to our program isn't it.
Thank you.
Well, thank you very much. This was a great talk. I mean, more great information for our community providers to use. So thank you so much for that. Speaking of information for our community providers to use, up on your screen, you'll see information about our new RAMP website. And for those of you who are not aware about RAMP, it's mental health care reference resources and curriculum for all of you. It's formed by a group of mental health specialists partnering with pediatric clinicians to expand mental health awareness and information. And you simply just go to Lurie Children's, ramp.luriechildrens.org for more information. And then for those of you who are viewing this online on our YouTube channel, just go ahead and click on the link below to either our Division of Adolescent Medicine. There's a link there, and there's a link also to the RAMP website. So since I don't see any more questions, I think we're going to go ahead and end the session. But before I do end that session, we do look forward to our next one, and that is today at 12:30. Session 6 will end this great virtual series that we have provided for you. And we're going to introduce you to Dr. Jessica Feuerstein, and she'll be talking about contraception for the primary care office. So I think that should be another great resource for you all. So I look forward to seeing you this afternoon. But until then, thank you all for joining us today.
Thank you.